Hello, everyone. I'm here today with Dr. Rizkallah. Everybody knows who Dr. Rizkallah is, but let's introduce him properly. He is an orthodontist in Massachusetts. He's also a real estate mogul. He has written the law we all know about. It's called Massachusetts Question 2. He's the president of the American Alliance of Dental Insurance Quality, which has three-part platform. It's an establishment of the dental loss ratio, pursuit of the Medicaid Act compliance at every state, and the fight against expansion of this VBC, value-based care. Everyone has seen the videos that we've had that mentions two of these parts. Today, we want to talk about this Medicaid compliance, Mo. I asked you to come here to explain this because myself and many dentists are not familiar with this. And if you guys stick around, my last question for Mo is going to be why a dentist like myself who doesn't participate in Medicaid should be paying attention to these laws. So let's hit the ground running. Can you tell us about this resolution that you want the ADA to adopt?
Thank you. So let me just frame a little bit for a moment the three-point platform that the American Alliance for Dental Insurance Quality, which I'm the president of and I established, what those three platforms are. I want to be clear about this. Point number one is to create a dental loss ratio. In fact, let me do this. Let me just share my screen. I'm going to show you our website real quick because the platform is right there. Do you see this?
Yes, I do.
So this is us, American Alliance for Dental Insurance Quality. Platform number one is dental loss ratio. We want to establish one in every state. And a quality dental loss ratio, not like what we see with NCOIL, which of course everyone knows my feelings about that and how we need to get out of that agreement. The second thing is Medicaid reform, and specifically relating to there are basically 5 laws that the AADIQ is targeting and saying we need compliance on those 5 laws because they would change dentistry even if you're not in Medicaid. And the third platform is no value-based fees, which is something that is currently threatening the profession of dentistry and all of its patients. So that, with that framework sort of setting the table, you asked me to talk about a resolution that I'm proposing that the ADA adopt. And so let me explain that. Let me pull up my screen again and show you that document. Do you see that?
Yes.
Great. So this is a resolution that the House of Delegates of the American Dental Association, in my strong opinion, should adopt fast. Let me read it to you. It has multiple parts. Resolved, the Health Policy Institute, HPI, shall investigate each state's Medicaid program for compliance with 42 U.S.C. 1396A30A of the Medicaid Act. And be it further resolved, the HPI shall produce a report outlining non-compliance with 42 U.S.C. 1396A30A for each state Medicaid program. So they're going to investigate it and they're going to create a report on every state in terms of their compliance. And be it further resolved, the Board of Trustees of the American Dental Association, in concert with the Council on Dental Benefits and the Council on Government Affairs, will edit and finalize the non-compliance report, which is produced by the HPI, for submission to the Center of Medicare and Medicaid Services, known as CMS. The report submitted to CMS shall also reference the relevant case law that requires full compliance by every state with the Medicaid Act, which I'll show you, that case law. And be it further resolved that the BOT, the Board of Trustees, will support states with litigation funds for federal level court actions, and I'll explain why federal level is the right place to be, not state level court actions. With federal level court actions, should litigation be required to enforce compliance in states that refuse to be compliant. So that's the breakdown. Let me come off screen for a second here. So what I'm saying here is the ADA should adopt a policy that takes the HPI, which is Marco Vucisic, and everybody knows my feelings about Marco Vucisic, but I'm saying let's give him instructions on what to use this very well-funded component of the ADA, give that directive to Marco and say, go in every state, investigate their compliance with that specific law, which we'll go through, come back with a report, and then we'll edit it, and then we'll submit it to CMS, Center for Medicaid Services, and tell them what they're doing wrong. We are going to investigate it and tell about it and complain about it at the state level. And if that doesn't do it to get those states to comply, we're prepared to sue them in federal court. That's the point.
Mo, you talk about these laws. What are they? Can you show me what this law is, the one that you mentioned?
Yes, so that's the right question. So 42 USC 1396A 30A is actually the most powerful law in Medicaid. It's the most powerful line in Medicaid. Most people don't know about it. But let me just say this. This law refers to children's Medicaid. It's specifically children's Medicaid, not adult Medicaid. Why is it children's Medicaid and not adult Medicaid? Because Medicaid does not require coverage for adults. It doesn't require. It requires Medicare coverage for children. Adults are optional. So any laws that you see in Medicaid are children's Medicaid. As it relates to children's Medicaid, what does this line say? I'm going to show it to you. And when I show it to you, it'll blow your mind because it's hard to believe a law like this exists. Let me read it to you and then I'll explain it. 42 USC 1396A 30A is what you have on the screen here. And it's hard to understand it initially, but let me read it once and then I'll parse it out. It says states must assure that payments are sufficient to enlist enough providers so that, in bold, care and services are available under the plan, at least to the extent that such care and services are available to the general population in the geographic area. This is powerful. Let me read it again and start to parse it out. What's it talking about? It's talking about payments. It's telling states must assure that payments are sufficient. Payments are sufficient. How many providers think that Medicaid payments are sufficient? None, right? This law is saying payments are sufficient. How sufficient? Sufficient to enlist enough providers. So you see, the analysis is not how much do you want? It's they need to have enough providers. So sufficient to enlist enough providers. So that what? So that care and services are available under the plan. To what extent? At least to the extent that such care and services are available to the general population in the geographic area. I'm going to break it down again because it's not enough to just read it 3 times. You have to read it 4, 5 times to really get the gravity of what this law is saying. It's basically saying, if you're not on Medicaid, you should have less access than someone who's on Medicaid. That's what it's saying. Where is it saying that? It's the word at least right here. This is where it's saying it. Care and services are available under the plan at least to the extent that it's available to a non-Medicaid patient in a geographic area. Now, why is geographic area important? And I call this, Mo's version of what this is, I call it the geographic area law. It's an easy way to describe it. Why in the geographic area? For example, in Massachusetts. Massachusetts is broken up into a more metropolitan area, then a more central state area, and then a western Massachusetts area, which we call loosely the Berkshires. Out there in the West, there's just nobody there. And there are people out there who don't have dentists. Those dentists need to be paid more. Why? Because that's what this law is saying. It's saying in the geographic area, if there's a deficiency in that geographic area, you need to make sure that there are more Medicaid providers available there. To what extent? To the extent that at least to what's extended in that area for general population. So nobody out there is even taking Medicaid. So we've got to make sure that the Berkshires or any portion of any state has compartmentalized their problem, their access problem. That's the geographic component of this. But setting aside the geographic component, what we just read together makes the Medicaid Act for patients under 21 years old the most powerful insurance on the planet. Now, how many people would believe that Medicaid is the most powerful insurance on the planet for any group, any population? No one would believe it, right? But it is. The reason they don't experience what it is because it's not complied with. And that's why I'm saying the Health Policy Institute should be doing what is really a simple policy analysis. And if they did this, they would change the country. And what I'd like to do, if you don't mind, is I'd like to show you some of the output of the HPI because it gives you some idea of the kind of good work that they do because they are quite capable of doing great work. So this is something that came out in October of 2021, reimbursements rates for child and adult dental services in Medicaid by state, and it's an infographic. And they go in, they contact the states, and they get the data, and then they put it onto a graphic, and then they send it out to us, and we all compare our states to other states and say, oh, we're under, we're over. None of us are happy, though. That's the thing. None of us. I believe there is no state, not one, that complies with the law I just read to you. And if we were to compile, the way that they compile data here, compile an infographic and say which states are compliant, and put a table next to it on what are they doing to comply or how are they failing to comply, which will go into what compliance looks like in a moment. We would change the country. You submit that report. The way I've written it, the resolution is that the HPI would produce it. They would submit it to the Board of Trustees, and the Board of Trustees of the ADA, in association with two councils, which I mentioned there, would edit it, polish it, prep it, send it to the Center of Medicaid Services and say, this is non-compliance. Now, going hand in hand, what I also wrote, if we go back to the resolution, what I wrote was, the report submitted to CMS shall also reference the relevant case law that requires full compliance by every state with the Medicaid Act. This is actually where the power is. What I showed you was the data. I get the data, compile it. But when you send it with this piece of information, which I'm going to show you what that is, it just knocks the doors down. Because what we're saying basically is, I've read you a law, but how much do you have to comply with that law? Let me show you. This document is a 2005 decision from the United States District Court, District of Massachusetts. This is federal court in Massachusetts. And the question here related to, skip forward to 15. I'm going to skip forward to the top of 16 first, page 16. It relates to 42 U.S.C. 1396A, which is the larger law in which 30A is included. So I've been citing 42 U.S.C. 1396A, 30A. This decision is talking about that package of laws. And let me go back to the previous page and get you a sense of how powerful this decision was. Section 2 of this decision is standard of review. It says, to this end, defendants argue. Who are the defendants? The defendants are the Commonwealth of Massachusetts, state of Massachusetts. They were the defendants, and they were arguing what? Defendants argue that any review of its conduct in connection with the instant case should address whether there is a failure to comply substantially with any such provision of the regulatory requirements for state Medicaid plans set forth in 42 U.S.C. 1396A. The operative word being substantially. The state of Massachusetts was saying, we have substantial compliance. Not full, but we just have to do substantial compliance. And I'll read to you what the court's decision was on this as we go through this. In other words, the defendants believe their conduct should be held to the standard of substantial compliance, not full or perfect compliance as urged by the plaintiffs. Let's skip down. However, nothing merits or implies the use of a low standard with respect to the Medicaid Act's program's fulfillment of its statutory and regulatory obligations to serve beneficiaries. Nothing mitigates the traditional expectation that a regulated entity fully comply with its governing statutes and regulations. I'm going to skip down and just go right to the heart of the decision. Accordingly, the standard to be applied in this case will be full compliance. Pow, pow, that's huge. And that's why I'm saying we need to file, if litigation is required, we need to file it in federal court. Why? Because this is a federal decision. It will influence future decisions. And you don't even need to file it in court because CMS knows. They know, and states know. What you need to do is to have a powerful organization like the American Dental Association compile this information, platter, and say, we know about this law. We know, and we're going to enforce it if we have to, but we want you to know we know that full compliance is required. None of these states are compliant.
Could you put that resolution up? What you're saying is that there is a law that states that Medicaid has to pay enough to attract dentists to an area to solve the problem of access to care.
And how do you get more dentists? Because every state's asking this. I can tell you, because the law tells you payment sufficient to enlist. It's not asking you to beg them. It's not asking you to invoke their altruism. It's telling you how to do it.
And the law says that. We're not saying that. The law says that.
Yes.
Now you're asking the HPI, which I don't know, not everybody knows what the HPI is.
The Health Policy Institute.
Right. This is a division of the American Dental Association headed by our chief economist to compile data to show that these states are not compliant with the law of the United States and say, hey, go fix it. And then help with funding to litigate this, to enforce it.
Yeah, take it to the CMS. Take it to the Center of Medicaid Service, which is a federal agency that oversees the Medicaid Act.
Gotcha. Yeah,
it's a federal agency, and that's why suing in federal court is important, because the federal court will respect its own laws and say, yes, Massachusetts, yes, Utah, yes, whatever state, you are taking federal funds, you must comply fully. What I really like to do is show you what that law really requires us to do. Okay, so if we go back to that law and we say, how do you figure out compliance? Like if you're Marco and you're trying to figure out how to determine if a state is compliant, okay? So let's just read it again and make a decision on how to do this. We need to figure out if the states are providing payments sufficient to enlist enough providers so that care and services are available under the plan. Okay, that's first part. Okay, we need to know how, if care and services are to what extent currently care and services are available under the plan. Okay, the way to do that is, the right way to do that is to contact do a poll basically regionally and say, how long does it take to get a root canal, a filling, a cleaning? And it has to be procedural, okay? And this is actually, there's a term at Center of Medicaid Services called mystery shopping. It's a common term, we know the term, but Medicaid uses this term, okay? It's a mystery shopper method, okay? You call up and you say, how long to get this? Call up again, how long to get this? How long to get this, okay? Now, the second part of this statement it starts with the word at least to the extent that such care and services are available to the general population. So the second part is basically saying you need to also do that for non-Medicaid providers. See? So you have to actually have two data sets and then compare them. It's a comparative rate structure, okay? People have all these theories about how do you make a rate structure? Oh, Medicaid should be 80% of Delta or whatever. You know, that's not the law, okay? You could say whatever you want. That's not how it's done. This is how you do it, okay? How do you set the rate correctly? You have to do a mystery shopper technique where you figure out how long it takes for Medicaid care and services access versus non-Medicaid. And you have to say, you know, if Medicaid is, 2 weeks to get a root canal, or in my state, in many cases, it's 6 months to get a root canal, okay? And you compare that to private insurance, okay? How long to get it? I'll see you tomorrow, or in a week, or what, okay? Now the question is, okay, we see the time disparity to get the care and services, okay? The access is different. Okay, we have to pay more over here until they are what?
Equal.
At least equal, Bob. Don't miss the at least.
Yep.
The at least is so powerful. What it's saying is more. It's saying if someone drops out, let's say you're equal, okay, and someone drops out, now you're slightly under, but you have to always be fully compliant, right? So it's not saying be equal. It's saying always be higher so that you never modulate lower. Full compliance. See what it's saying? Now, that's why I said earlier, this is the most powerful insurance plan on the planet for 21 and under. Okay, it's amazing. Okay, and when and we'll get to it at the end, this affects private insurance. Okay, now what I want to do is show you how actually easy this is to do. Okay, but how I'm not really the one should be doing it. Okay, it wouldn't be hard for me to do this in every state. I could, okay? I could take my staff and say, go do this, okay? This does not need to come from Mo or Rizkallah. It needs to come from ADA, okay? How easy is it to do this, okay? Let me show you what I got from the Massachusetts state when I did a public records request. I contacted them. I said, give me your entire access overview for Medicaid, okay? Because you have to comply with that law. They know that law, okay? I said, show me how you comply with their access, okay? So what they did is they sent me on the left side here, you're seeing all the pages of this 79-page document, okay? This document was produced by my least favorite third-party administrator, DentaQuest. They are a terrible administrator, okay? And I would say, and we just ousted them in Massachusetts, and I had a hand in that, okay? And I will tell you, any state that has DentaQuest, try to get rid of them. But back to what we actually received from DentaQuest. DentaQuest did at the time. DentaQuest has been running our state Medicaid program for well over a decade. Okay, and what they did is they produced this document. What is this document? You'll see there's an infographic at page 2, and then there's another infographic at page 22. Okay, so page 2, if you look at what it says under access analysis, it's saying GP access. You see that there? Mm-hmm. Okay, on page 22, it goes to the next access, and it's talking about ortho access, and then it has pedo and oral surgery access. But let's just look at GP access, and I'll show you what they did to evade the requirement. What they did for GP access and all of the access levels is they made it so that their analysis was minutes to a choice of providers. And what they said was, if a person can get to their choice of providers within, 3, 4, 5, 6, 7, 8, 9, 10 minutes, 10 minutes, and that's what they have there, they have full access. But that's actually a cop-out, okay? Because what that's measuring is access to what? The doorknob.
Right.
The doorknob.
Telephone.
The doorknob. But when you go back to the law, what does the law actually say? The law is saying, so that, and I bolded it, care and services. It didn't say doorknob, okay? It's not enough to get there and have them say, I can't see you for 6 months, okay? Access is not to the doorknob, it's to the service, you see? And so so in Massachusetts, as we've removed DentaQuest, we have happily adopted in Benecare. Benecare does this. They do the secret shopper analysis. And we're going to be seeing, because we have the right third-party administrator in there now, we're going to be seeing the truth about our comparisons. And then guess what? We have to then follow the law, which is adjust rates so that patients have the access, okay? So now let me show you one more thing. How hard is it to do this? It's so easy. So I got that access overview, okay, the documents. I sent a public records request. Here's a follow-up public records request. This is coming from Commonwealth of Massachusetts, September 14th, 2023. I had sent them an email, and I said to them, this is a public records request. Who is the contract vendor that complied with this data? Please send whatever else they submitted in the package when they provided the access overview to the Commonwealth. It's as simple as that. It's a quick email, boom. It's not even formal words. It's just me saying, give me. Okay, and what do? So I sent that to them. What date? August 1st, 2023. By September 14th, 2023, they gave me my answer. They said, the report submitted by EOH's contracted vendor, DentaQuest, and they answered the rest of my questions. But typically, you'll have this within 10 days to 40 days. You'll have this, okay? The HPI can do this efficiently. Compile it, send it to CMS, change the profession. Now, having said all that, I think it maybe makes sense at this point for me to go back now. I'm going to come off screen and maybe go back now to your original question. Okay. Actually, let me say one more thing. I have a point that I wanted to make in my notes. I want to say this. What I just described as a resolution is an easy win. Okay. What I find in our organizations is that we pursue things that are meaningless and will never win. Okay. And if anybody knows what I do, like I point and shoot at the things that I know are big, easy targets. Like question 2 was a big, easy target. I'm pitting patient access to care against bad insurers. Okay. And who votes? The patients. That's a really easy win. Okay. For me, it seemed obvious. And we got a 72% win. That's an easy win. Okay. This resolution that what I'm proposing is also an easy win. Why? Because the law exists. Not only does the law exist, the interpretation of case law exists and requires full compliance. This is just shooting fish in a barrel. Why are we not already doing this? I don't know, but this is what we should be doing. And compare this to other things that I think are wasteful that we do. Like, I keep hearing the ADA talk about ERISA and chasing ERISA. Let me tell you, and it's my prediction, you will never change ERISA. And if you just keep chasing it, all you're going to do is make enemies. Okay. And ERISA doesn't even need fixing. Okay. Leave it alone. But if you want to waste time, energy, and money, keep pursuing ERISA. If you want to make your time, what's that?
I'm going to explain. ERISA are the self-funded plans, such as unions that you're talking about, right?
Yes, self-funded insurance plans, which are controlled at the federal level, and you're never going to modify those. They're so highly protected, and you don't need to protect them. And I don't want to get off point, but ERISA plans don't need to be regulated because anyone who's running an ERISA plan is a fiduciary. If you want to regulate a fiduciary plan, you take them to court. Right. You don't try to regulate them through law. You take them to court and say you're not being a good fiduciary. That's how you manage an ERISA plan. But we waste our time on these. So the point is that what I'm proposing here as a resolution is a slam dunk. So now back to your last question. If you could sort of repose that to me.
What I want to know is that why should I even pay attention to this, Mel? Well, I know many dentists say, oh, I don't want to get involved with Medicaid.
Right. So this is a really interesting misunderstanding. People say, I don't care about Medicaid because I'm not in Medicaid. Yes, you are. You just don't know you're in it. Okay. So Medicaid is a set of laws, and it is governed by the Center of Medicare and Medicaid Services. Okay. Now, Medicaid pervades all of healthcare. Okay. It sort of sets the bar for what does the government believe is the standard for healthcare. So, for example, everybody knows that I work closely in medical loss ratio. Okay. The medical loss ratio laws essentially are governed at the federal level by the Center of Medicaid Services. People don't know this. Okay. I'll go a step further. Insurance standards in terms of the loopholes that insurers can use in terms of charitable contributions, where to put their, are they allowed to pass through broker fees to patients, or do they have to pay them out of their administrative fees? All these questions. That's governed by Center of Medicaid Services. Okay, people don't know this. Okay, here's one of my favorites is the term medical necessity. People don't know what that term even means. Okay, sadly, people think dental care is not in the word medical necessity, but it is. In government, the term medical necessity refers to anything associated with your body. Okay, so dental, vision, hearing, everything. If you need care, it's covered under this term medical necessity. The medical necessity standard of what must be covered is the most interesting and frankly beautiful language that you'll find in Medicaid laws, state and federal Medicaid laws. Beautiful language that talks about really what it needs to be covered under medical necessity. That applies to dental. Okay, those standards are established where? In the Medicaid Act. Okay, so when you're saying, they won't cover that for my patient, they won't cover it because the Medicaid Act doesn't require it. They're allowed to hide behind the government standard. But it's worse because they not only hide behind the government standard, they create it. The insurers create that standard and influence the standard. And you got to really absorb this, okay? So I have already said DentaQuest. I hate DentaQuest. They're terrible. They should be shut down as far as I'm concerned in every state, okay? But why? Because DentaQuest is not just a third-party administrator. DentaQuest is an insurer. And what they do is this term called regulatory capture. What that means is that because they manage state programs, they're basically like quasi-government. They're not really government, but they basically take the contract of managing governmental affairs. So they act like government. They oversee like as if they're government. They behave with an authority, like, don't take us off because we'll come after you. We're the government. But they're not government. They're quasi-government. Okay. So what do they do in this regulatory capture? Well, regulatory capture is the instance where a regulated entity, like an insurance company, which is regulated by the Division of Insurance in every state, okay, is able to get up behind the Division of Insurance and puppet the Division of Insurance, which controls it. So it has controlled its regulator. That's what that is regulatory capture. This is one of the reasons I've always said that third-party administrators in the Medicaid programs should never be allowed under conflict of interest clause. They should never be allowed to manage a Medicaid program if they have private insurance affiliations. And so what they do is they go into these third-party administrations. They get paid every month, $1 million a month or whatever, okay? They get paid, and they then set standards, and they convince the state to adopt standards. And what do those standards do? Those standards make it so that it's harder to get approved for something, okay? And then the states are like, oh, you mean you can save us money by making a limitation on crowns that's 5 years? Yeah, we could do that. Is it okay to do that? Oh yeah, it's okay to do that. Okay, well, fine, let's do that, okay? Then the state adopts it. Then what do you think the private insurance does? They adopt it, okay? And the Division of Insurance, who would say, hey, why are you doing that, would be corrected by saying, oh, well, we're just following what the state did, never mind the fact that they're the ones who did that, okay? This is the cycle of regulatory capture, and that's why it's important that we have a robust Medicaid program, because then the private insurers cannot hide behind the argument that, well, the government says that that's okay for medical necessity, and everybody knows the Medicaid program is a robust program. So they wouldn't do that unless it was the right thing to do. See? So all that to say is that Medicaid policy and I've just touched on a handful, okay, of ways that Medicaid policy controls private insurance. So you really need to be, even if you're not in private insurance, you need to be thoughtful about making sure Medicaid is supported, and because it does end up dominating, not even just affecting, it ends up dominating how your insurance plans are covered, what the rates are. It affects UCR. It affects all of it. So that's not a thorough answer, okay? But I think it captures enough to make my point.
Yeah, for sure. And I want people to pay attention that it has a domino effect. What Mo is trying to say is that it's set at a federal level with the Medicaid, the private insurance follow it. And if you think oh, I don't take any insurance, I'm clear. No, your patients choose to come to you. They use insurance to come to you. So it affects everyone. Medicaid doctors, PPO doctors, fee-for-service doctors. This is important to get involved and influence the ADA so they can do the work for us. Why am I relying on an orthodontist from Massachusetts to do this? We need the resources and the infrastructure the ADA already has in place. This is why I tell people, don't sit on the sideline and say, I'm never joining. You need to join so we can have your support, so we can go to the ADA and say, this is what we want.
And let me just say, people must think I'm bipolar or something in the sense that on the one hand, I'm a huge critic of what's happening at the ADA, and then on the flip side, I'm like, you can't leave the ADA. You need to join the ADA. But I say it again and again. You cannot just join the ADA. You need to join and be involved and scream. Right. For the people who are saying we need to create a new organization, it will not be different. They're all the same. It's the same people not having purpose-driven mentalities. And until the practicing affected dentist and who has affected patients is coming to the table and saying, no, I want this. This person makes sense to me. I want this. This person doesn't make sense to me. I don't want this. Okay. Until you're involved, not just blindly delegating, any organization is going to be this way. So let's not drop the ADA. Let's steer it.
And that's exactly my mission have been, that we need to join the ADA and make sure our voices are heard. What Mo is saying basically, great, thank you for being a member, writing the check. But if we don't hear from you and we only hear from you once every 5 years, they're going to do whatever they want to do. Hey, I want to thank you for being here, Mo, and I want to tell people that I want to have a couple of these conversations for you to explain to us this whole gamut of things that you have put together that improves our patients' oral health, and in turn, our small businesses, which are dental offices.
And I believe our next video is going to be on value-based care,
right?
Which is so important that people understand what that's all about and how it's going to shape us if we don't nix it.
Thank you very much for being here, and hopefully we can talk later.
All right, a pleasure.
Thanks.